Our next presenter is originally from Southern California and attended BYU in Hawaii for his undergraduate degree. He is currently a first-year perfusion student at Rush University Medical Center in Chicago. And when Brandon is not in class or studying for school, he enjoys walking with his wife and their 8-month-old puppy, Charlie. Please join with me in welcoming Brandon Geurts, speaking on ECMO as a bridge to lung transplantation.
Okay, thank you, Susan, for the introduction, and thank you, Madeline, for that presentation. So before this, Bill Harris was mentioning that as a student, he presented on ECMO, and I'm also presenting on ECMO and its possible use as a bridge to lung transplantation. And like Bill, I have a lot to say, and I'm really excited, so I'm going to jump right into it. So as you can see over the years, there has been an increase in the amount of lung transplants, and in 2019, there was an all-time high of 2,714 lung transplants. Although there has been an increase in the amount of lung transplants over the years, this hasn't met up with the demand. So we have seen a big increase in the amount of people on the waiting list. And although the donor pool has been attempted to increase through government efforts, this hasn't kept up with the amount of need for the vital organ of the lung. However, there could be a possible solution as the use of ECMO can be utilized as a last resort option to extend the patient's time to find a match. What is ECMO? I'm sure many of you are very familiar with ECMO, so I won't dive too much into the subject. But basically what ECMO is, it's an extracorporeal circuit that takes deoxygenated blood from the patient, oxygenates it, and returns it back to the patient. And there's two main types, which is VA ECMO and VV ECMO. And the purpose of my study is to explain the benefits and drawbacks to using ECMO to extend wait time for patients who are waiting a lung transplant. So the first article that I wanted to discuss is found in Cardiothoracic Transplantation, and it's titled, "Should Lung Transplantation Be Performed for Patients on Mechanical Respiratory Support, the U.S. Experience?" And this research divides the patients into 3 groups, and they're divided on the support they receive before their lung transplant. So the first group is mechanically ventilated patients. The second group is ECMO-supported patients, and the third group is unsupported patients preoperatively. It's also important to note that the patients that are supported by ECMO and that are supported by mechanical ventilation are younger in comparison to unsupported patients. Also, the propensity score, with the adjustment for propensity score, the hazard ratio was 1.5 for mechanically ventilated patients in comparison to unsupported patients, and it was 2.55 for patients on ECMO compared with unsupported patients. So essentially, patients that are supported on ECMO or mechanically ventilated have a higher risk for mortality in comparison with patients that are unsupported preoperatively before lung transplant. And this research was particularly interesting. On the right-hand side and the top right corner is a graph that depicts the survival percentage for unsupported patients in blue, mechanically ventilated patients in green, and ECMO patients in red post-operatively. So it shows their survival percentage after their lung transplant. And as you can see, the unsupported patients demonstrate a higher survival percentage in comparison to the mechanically ventilated patients and the ECMO-supported patients. However, on the right side below that, there is a graph that shows the death percentage per year. And around 1 year, you notice that the death percentage per year begins to even out, and there's comparable results among all 3 groups. So this suggests that there's a high risk early phase for ECMO and mechanically ventilated supported patients 9 months post-operatively. However, after this high risk 9-month period, the outcomes are similar among all 3 groups. So an interesting takeaway from this article is that Although unsupported patients have a higher likelihood survival post-operatively compared to ECMO and mechanically ventilated patients, once the 9-month mark is reached, they have similar results. Additionally, this poses the important ethical issue of if ECMO supported patients and mechanically ventilated patients are at a higher risk, then who should get the lung with the lung being such a vital and limited organ, and there's not a very large supply of such a vital organ. The next research that I wanted to talk about is found in thoracic lung transplant, and it's titled 20-Year Experience with Extracorporeal Life Support as a Bridge to Lung Transplant. And so this study is particularly interesting because it talks about ECMO-supported patients, and it divides them in 3 groups based on the year in which they received their lung transplant. So in the first group, we have 1998 to 2004, the second group from 2005 to 2010, and the third group from 2010 to 2017. I also wanted to highlight the bridging modalities that were used over the course of the years. So in 1998 to 2004, primarily VA ECMO was used as a support to lung transplant. However, as the years progressed, we see different bridging modalities, and VV ECMO was being utilized a lot more in more recent lung transplant candidates. Also, the type of transplantation has evolved as well, and that currently 47.6%, or almost half, of the lung transplants are whole organ, whereas in 1998 to 2004, only 9% or one individual received a whole organ transplant. And the results of this study are particularly interesting. On the right, we have a graph that depicts the survival probability among all 3 groups. The first era, or the 1998 to 2004 group, is depicted in blue, the second era in red, and the third era in green. So we can see a gradual increase in survival probability over the years as ECMO has evolved. And I wanted to point out particularly the 1-year survival probability for each group. So for the first era, it was 44%, the second era, 51%, and the third era, 77%. So we've seen a significant increase over the years in survival probability among these patients. So some key points from the article are, as more patients were bridged to ECMO, in the first group only 11, and then in the third era up to 70, we have seen a decrease in waiting list mortality. So as more people are put on ECMO on the waiting list, less people are dying on the waiting list. And a constant improvement has been observed with patients that are bridged to lung transplant by the support of ECMO. The last article that I wanted to talk about is titled Active Rehabilitation and Physical Therapy During Extracorporeal Membrane Oxygenation While Awaiting Lung Transplantation, a Practical Approach. And this is found in Critical Care Medicine. This article is interesting in that it's a case study that talks about 3 patients with end-stage respiratory failure, and it talks about how ECMO was used in their rehabilitation process before their transplant. So the healthcare professional team decided to cannulate the patients with a double lumen Avalon cannula, and they inserted it in the right internal jugular vein. And this was important because it allowed the patient to walk, and it assisted in their rehabilitation process because they weren't cannulated femorally, so they could walk and use their legs. And I wanted to talk about one patient in specific. I would like to talk about all 3, but due to time, I just wanted to go through one patient and the sequence of events that led to the lung transplant. So patient 1 was a 16-year-old with cystic fibrosis. Over the 5 days since admission, they attempted to wean her off mechanical support, but each success off the ventilator was unsuccessful. So the healthcare professional team ultimately decided to cannulate the patient for ECMO. After a week of strength and reconditioning on ECMO, the patient was able to stand with assistance and walk around her bed. After 8 days on ECMO, the patient underwent transplant, and 24 hours the transplant, she was transitioned to trach collar and was participating in physical therapy post-operative day 2. She was ultimately discharged home 32 days after her lung transplant. So some key points from this article are that the use of ECMO in the rehabilitation process for patients is something that is difficult but possible. A big commitment from everyone in the team, including physicians, nurses, ECMO specialists, respiratory therapists, physical therapists, and perfusionists, is needed to help the patient improve while they're on ECMO. However, this commitment is needed for the patient as well, as they need to participate in the recovery process. Although ECMO can be used as a bridge to lung transplantation, this is not without complications. Some complications that I found in the research were blood clotting, vessel injury due to cannulation, and additionally, as I pointed out, survival is still better among non-bridge groups. Also, centers that are unfamiliar with ECMO or low volume centers report additional adverse outcomes. And there's also the idea that patients that are on ECMO for a longer time increase their mortality probability. So we have to get the patients that are on ECMO a lung in a timely fashion. There's one more additional complication that I like to point out specifically, and that is creating a bridge to nowhere. So because there's no destinational device therapy for respiratory failure, it's possible to create a bridge to nowhere. And I wanted to point out an example to illustrate this idea, and where a 25-year-old woman who is a lung transplant candidate was put on VA ECMO to maintain her transplant candidacy. However, while she was on ECMO, she developed renal failure, and this deactivated her from the transplant list. However, she was still awake and conversant, but she kind of had nowhere to go, and this put everyone in a difficult situation, the patient, family, and the healthcare professional team. I would like to point out the benefits of using ECMO as a possible bridge to lung transplant, and that patients on ECMO are more likely to receive a transplant due to the higher lung allocation score. You can also use ECMO with the addition of active rehabilitation and conditioning to improve post-operative outcomes. And as I mentioned earlier, with the use of ECMO, there has been a decrease in waiting list mortality. In conclusion, ECMO has been used as a support to help patients that are waiting a lung to receive a lung transplantation. Although this is a viable option, it's not without complications, and it's essential to avoid a bridge to nowhere. As centers are becoming more familiar with ECMO, as we saw in the second study, the outcomes have become more favorable. And it's also important to note that with the use of ECMO, it's important that everyone assists in the rehabilitation process, and that the rehabilitation process is really what brings about the positive outcomes with the use of ECMO as a bridge to lung transplantation. Thank you, everyone. I would like to thank perfusion.com for the opportunity to present, and specifically my professors, Julie Collins and Jim Murray, as they helped me prepare for this presentation. Here are some of my references, and I would just like to open up to any questions.
Thank you very much, Brandon, for a very nice presentation. As we've talked through this meeting here, there's a lot of literature that suggests that ECMO could be a viable option for bridge to transport in lung transplantation. So what could be done to improve the survival rate among our patients that are supported by ECMO prior to lung transplantation?
So I think a big thing, so as I discussed earlier, there was a high risk mortality rate early on post-operatively. And I think something that would be beneficial to this is assisting in the rehabilitation process, as I pointed out in the third article, with the use of physical therapy and attempting to strengthen the patient and not just let them sit there on the bed. This, I think, would be very beneficial in improving outcomes post-operatively.
Okay. Any other questions? In lieu of time, thank you very much, Brandon.
Yeah.